Good morning, everyone. I'm Dr. Tara Kiran. I'm a family doctor at St. Michael's Hospital and also the Vice Chair for Quality and Innovation at the Department of Family and Community Medicine at the University of Toronto. I'm really pleased that our department can co-host these sessions with the Ontario College of Family Physicians and have been bringing them to you now for, I think, 16 months. I'm going to turn it over to my colleague, Liz Muggah, the president of the OCFP, to introduce.
Good morning, everyone. Great to be back with all of you. Hopefully you've had some holiday or will have some still to come. So important right now with everything we've been doing. Delighted to welcome our two panelists, Dr. Stephenson from Huntsville and Dr. Allison McGeer, and David and I are here as well. And this is MainPro accredited as per what's on the slide. Next slide, I'll just read the land acknowledgement. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. And I invite all of us to reflect on the territories that we're calling in from. I'm in Ottawa, unceded Algonquin and Anishinaabe territory, and commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. I'll pass back to you, Tara.
Thanks, Liz. So I know in our latest issue of Canadian Family Physicians, I thought there was a really timely and important article about preventive screening for people who are Indigenous, and it really takes us back to, the roots of colonialism, discrimination, oppression, and how that ties into what we might be seeing in our clinics today, and provides some, I think, really practical kind of thoughts for how, as family doctors, we should approach it. So if you haven't seen this article or read it, I highly recommend it. Next slide. Next slide, Brian. Yeah, so we've been bringing these sessions to you for the last 16 months, and some of the things, we're going to answer your questions today, but there are many sessions on record that you might want to check out. So check out that website, and you can always do a past session. It's MainPro accredited. And so if there's a question that you didn't get answered today, chances are it was answered in a previous session, and I urge you to take a look at those. Next slide. I'm delighted to welcome our panelists today. And next slide, Brian, I'm just going to turn it over to them one by one to introduce themselves. So Megan, I'm going to turn it over to you first.
Good morning. Thank you very much. I'm Stephenson. I'm a rural generalist family physician working in Huntsville for the last 21 years.
Great. Allison, are you able to go next?
Sorry, typing in chat. I'm Allison McGeer, Infectious Diseases at Sinai Health System.
Can you just speak to your disclosures as well, Allison? Because I think there's a problem with our slides, but I think you could speak to them.
Okay, yes. So I have, I do a lot of work with vaccine companies, and so I have a long list of relationships with most of the companies that make COVID-19 vaccines.
David Kaplan?
I'm David Kaplan. I see my picture continues to be stretched. That's okay. But I just laugh every time I see it. I'm a family doctor at the NorthTerm Family Health Team in North Toronto, and actually no longer the Chief of Clinical Quality at Ontario Health, but the Vice President Quality at Ontario Health for the last couple of weeks. So welcome everybody, and thanks for joining us in the summer.
Liz?
Yep, Liz Muggah. I'm a family doctor in Ottawa, and I get a stipend for my role as the president of the OCFP. No other conflicts.
And I'm Tara Kiran, and I've listed conflicts, or I should say, just a number of organizations where I've gotten grants or salary support. The only one that's for-profit is Gilead Sciences for a grant on hepatitis C. So unfortunately, I think I'm experiencing technical difficulties. I think everyone else can see the right slides, but I'm not seeing the right slides. So just forgive me. Can other people see I'm just going to do a check here. Liz, can you see the right slides?
No, it's on the intro slides. Hasn't moved forward.
Yeah. So Brian, I think everyone can't see the right slides. So maybe can you end slide and restart, and let's see if we can. Yeah. Now we're seeing. We just saw the slides. So if we can go what we'll do is we'll pick up where we were. Perfect. Next slide. And I don't think we're seeing, yep. And then the next slide. Great. So thank you to all of you who are joining us today from all over Ontario. Next slide. I know so many of you, we already have close to 500 people on the line, and most of you are familiar with how we interact here, but if you have questions, please do put them in the Q&A box. We have almost 900 registrants today. What we'll be doing is prioritizing the ones that get the most thumbs up. So the best option is to take a look and see if there's a question that really matches what you want to ask instead of typing your own, and then do a thumbs up. If you don't see your question asked already, then of course type it away. And please do look at the answered, because our panelists do an incredible job answering in the text. And a reminder that we will be circulating the Q&A afterwards as for the summary of that. We post that on our website along with the recording. The chat is an awesome opportunity for everyone to just interact and for you to share your own thoughts. We're going to be talking about, some interesting topics today, including ramping up in, in-person visits in our offices. And I know there's different opinions and different practices out there. So please do just join the chat and share, what you're doing in the chat. But if you have a question, put it in the Q&A. Next slide. So I'm delighted to just turn it over to Dr. Megan Stephenson to start us off. We invited Megan actually to join us today because she was so active in the chat at our last community of practice when we were having a really rich discussion about seeing people in person. And she mentioned how she'd been seeing people in person a lot during the pandemic. And she's here to tell us a little bit more today about what she's been doing in her practice. So Megan, I'm going to turn it over to you.
Thanks very much, Tara. So I've been asked to present a brief summary of how to see patients safely in the office in family practice across Ontario. And so I'd like to start by talking about some statistics, and then secondarily to advocate why we should be seeing patients in person, and thirdly, how to make this happen. So as you can see, that first slide shows a graph, and this is currently unpublished data, which is a follow-up to a study published by our very own Dr. Tara Kiran, published in the CMAJ January 2021, showing the weekly primary care visits by type, office, home, or virtual from January to December 2020 compared to total visits from the same time period in 2019. And so the study authors concluded that compared to 2019, total primary care visits between March and July of 2020, so early going in the pandemic, decreased by 28%, that office visits alone decreased by 79%, and virtual care visits increased by 56-fold, comprising 71% of total visits. Thanks, Brian. So as of July 2021, on average across Ontario, 50% of primary care visits are in person, and I'd like to suggest that this number can probably be safely increased to 80%. Virtual visits remain appropriate for following up lab results or for counseling, but all other appointment types can safely be seen in person. There's no need to differentiate between vaccinated and unvaccinated patients when you're seeing patients in the office. The more important distinction is distinguishing between symptomatic and asymptomatic patients. I completed an office audit between April 1st, 2020 and July 31st, 2021, so about 16 months over the pandemic. And based on my billing data, this revealed that 87% of my patients were seen in person over that time period. My office has never been closed and the office door has never been locked. And so perhaps I'm an outlier, but subsequently I was approached by the OCFP to offer my perspective and to discuss how this can work in family practices across Ontario this fall. So why should we see patients in person? Well, we're trained to look after sick people. We make enough money to supply ourselves and our staff with PPE. Because ordering tests or referring to specialists without an assessment creates potentially unnecessary interventions, creates delays, and leads to increased patient anxiety. We also should avoid sending people to the emergency department if these resources are not required. Seeing patients in person in the office is the most cost-effective way of providing primary care, and that's been borne out in the literature time and time again. Seeing patients in person in our offices will reduce morbidity and mortality of our patients, and I could spend a whole other hour talking about the non-COVID victims of the pandemic. And lastly, because we were immunized early and we do have a degree of protection. So how do we make this happen? Well, active screening should be undertaken by your staff when patients call to make a phone or to make an appointment. You can also use any number of web-based programs to do your COVID screening questionnaires. Passive signage should be placed on your office door, and I assume most offices are doing this already. You can install a plexiglass barrier between your reception area and your waiting room to protect your staff. You'll want to minimize congestion in the waiting room. Patients should arrive alone and they should be masked. If they need a support person, then this person's name and phone number should be recorded on your day sheet or in your appointment book in case contact tracing is required. Remove all extraneous items from your waiting room like toys, magazines, and books. Keep a small number of chairs for your physically disabled patients, a minimum of 2 meters apart. And obviously make hand sanitizer available in your waiting room and in all of your exam rooms. We've numbered all of our exam room doors so that when patients come into the waiting room, they're not hanging out there. They're immediately directed to a numbered exam room by the staff. So there's no interaction between staff and patients. Patients go to the assigned room, they go in, close the door, and wait for us there. Less extensive and less frequent cleaning is required now that there is less evidence of the virus being present on fomites. Right now, we're just wiping down the exam table, the chairs, and the doorknobs between patients, and that's it. When you see patients who have symptoms that align with COVID, it's probably prudent to see them at the end of the day. You do need to wear full PPE. So that's a surgical mask. You don't need an N95. Eye protection, gloves, and gown. Take your viral swab into the room with you. Do your assessment, do your nasopharyngeal swab, have the patient exit the examination room, and in fact, right out of your office. They're not stopping in the waiting room. I come to the door of the examination room. My staff is waiting there with the plastic bag for the virus. I pop the viral swab into the bag. Everything's already labeled. My staff for this task wear a mask and gloves. I retreat back into the examination room and I clean the room. It takes 90 seconds. There's no point in wasting a whole other set of PPE if you're already in the room. So I'm cleaning horizontal surfaces. I'm cleaning anything that the patient may have touched. Obviously, medical equipment involved in the assessment, blood pressure cuff, otoscope, thermometer, what have you. I clean the top of the hand sanitizer pump. I doff my PPE in the room, hand sanitize, exit the room, close the door, let any aerosol particles that are in there settle overnight. And we typically try not to use that room again. We should avoid delaying assessment and treatment of patients who have COVID symptoms that overlap with their pre-existing health conditions like asthma, COPD, CHF. I see those patients, I do test them for COVID, but I know that the likelihood is that, statistically, they probably just have an exacerbation of their condition. We should also continue to see people with infectious illness, tonsillitis, sinusitis, otitis media, pneumonia. These things are extremely common and we can safely see these patients. But again, if their symptoms align with COVID, we should be swabbing them as well. And as per the CPSO, July 26, 2021, in-person care cannot be restricted to those who've been vaccinated or provide evidence of a negative test. And if I could have the last slide there, Brian. This shows a picture of my office. So the picture on the left is my waiting room. It's not particularly big. Right now it has 3 chairs in it, spaced 2 meters apart. There is a plexiglass barrier there separating the reception area from the waiting room and a little pass-through window, which is difficult to see. And there's obviously hand sanitizer there on the counter. The picture on the top right shows how we've numbered the exam room doors. And the picture on the bottom right shows that my hallways are no wider than yours. On any given day in those 5 exam rooms, we will have 2 physicians, 2 admin staff, an RN, and possibly a medical student and resident as well. So listen, people passing in the hallway that are masked and they're passing transiently, even if they are COVID positive, the risk of transmission is exceedingly low, and this is a safe undertaking. And that's all I have to say. Thank you.
Thanks so much, Megan. So you've certainly accomplished what we wanted, which is a great dialogue in the chat. So yeah, I think Liz and David are reading that chat as well. And, you know, I want to bring out some of the points that people have kind of raised in the chat. I guess to start, Brian, I'm going to ask you to go to the next slide because people did say that they wanted to see some of this new data. And so David Kaplan, you kindly shared this data with us from Ontario Health. And this data is actually stratified a little differently. So I think it basically shows the percent in-person visits over the period from April 2020 to this one ends, I think, in June. So it goes up till June. And so you can see a steady increase in the proportion of in-person visits to about 70%. And I think now when we look at the graphs, we can see that the total amount of visits in-person plus virtual has reached previous levels. Although we have to take that a bit with a grain of salt because we know many of us have, you know, often practiced by seeing someone virtually and then bringing them in person. So there's some duplicate visits there. But one of the things it's helpful to see in this graph is that we can see that there's a large variation actually in the proportion of in-person visits. So I said from 50 to 70%, but that was in the north actually. So the pink line at the top is the north region. And the orange line at the very bottom is the Toronto region. So there, in-person visits dropped to 30% following the pandemic, and then has slowly risen and kind of are now, it seems like, at about 45%. So real variation by region. And we also know that there's a lot of variation even within one practice. So I do want to also acknowledge that, you know, I think the vast majority of family doctors have been open during the pandemic, and we've certainly done work even in Toronto to look at this. And we know that, you know, 90% of family doctors that we talked to, that we called, were open in person. That was even during the first wave of the pandemic. And 98% were open in person or virtually. So the vast majority are seeing people in person. So I do want to acknowledge that. So David, I know you noticed you have your hand up, and then I know there's also some other great comments in the chat I want to get to.
Yeah, just I wanted to highlight that what we don't see on this slide, because we're not looking at individual patients, is there's still about 1.2 million patients in 2021 that typically would have a visit to their family doctor who have not, either virtually or in person. And so there's this vanishing 1.2 million Ontarians that have not sought any sort of medical care that historically would have. And Tara, I think that's really important that you highlight that some of the visits are duplicated because we're seeing some people in person first and then virtually. So there's definitely a care deficit that's being also driven by patients not seeking care that I think we should highlight.
Thank you. Maybe we'll go to the next slide. I know many of us are thinking about, you know, how do we get to that right balance? What is that right balance? And I guess I've written my thoughts in this blog that you may have seen. And, you know, in my own practice, I've tried to move to what I call a patient-directed approach, where patients can make the choice. You know, are they going to, like, they can say, are they going to come in person or virtually when they first talk to the receptionist? They can put that down. Now, of course, there are times where I want to see them in person and I'll ask them to come in. But there are many times, but in the past, we've really had this virtual first approach where we've had to kind of screen out people and say, okay, first, let me talk to you on the phone. Okay, now you can come in. And I think now I feel comfortable leaving it to my patients to say, identify that they think they have a problem that needs them to come in, or sometimes they just want to see me. And sometimes that I've found is related to mental health. So I've also kind of put here what I thought some of my proposed in-person priorities were, and I know the OCFP and others have kind of put out lists or are putting out lists as well. Next slide. I also wanted to remind people that, you know, of course, the virtual visits are going to continue to be a big part of our practice. And I wanted to just draw attention to some of the great resources on the Center for Effective Practice. So this is one we worked on with them around a framework for managing chronic disease and balancing in-person virtual visits, and when virtual and telephone and email might be, or secure messaging might be appropriate, and when we might need to bring them in. So I think these kind of resources are hopefully helpful. There have been so many comments in the chat and I just want to pick up on a few. I mean, I think people did say that a couple of people I think felt, took issue with that you said, Megan, that we all had making enough money to supply our own PPE. I think some people didn't feel that way. They felt that maybe that's not the case. And they did talk about how many have been open, that many of them have, of course, been open as well. And they talked about the issue of specialists not being open, and also the unhelpful rhetoric of family doctors being closed that we're getting from specialists in the context of even them being open. There are some sort of questions for you. For example, how do you space out these 30 your appointments? Is it every 15 minutes, every 10 minutes, every 30 minutes, in order to do some of that what you've described? And maybe I'll just pause there and give you a chance to respond to those before I go to some of the next ones.
Sure. So I haven't changed anything in terms of how I'm booking patients. So I am booking them 15 minutes apart. Virtual visits, while I guess see about 13% of patients virtually are interspaced, but with no rhyme, no reason to my schedule. Obviously, if you are concerned about traffic in your office, maybe you block off times in your day where you have a break with a virtual visit so that the rooms can be cleaned appropriately. And if you feel like there are higher risk individuals around that time, they can be seen in person and then followed by a virtual visit, so there isn't a lot of hallway traffic. With respect,
so just building on that, Megan, I just wonder how many, sorry to interrupt you, but somebody also asked, how many rooms do you need if you have several people who need to be seen for COVID type symptoms?
Right, so we have 5 examination rooms. Do we see them at times other than the end of the day? Well, you have to, I guess. We have 3 physicians in our office. We're part of a FO. But there are only a maximum of 2 of us in the office at a time. So we try and book those patients at the end of the day. Our COVID assessment center is closing the end of this month, so we will no longer have that option of sending people there. Yeah, I think with proper cleaning and so on, it is doable. I don't know. I don't really have any good answers.
And so then there's a lot of discussion in the chat just about the surge that people are anticipating of influenza-like illness, or ILI. I think some people are saying too many acronyms. But so I think people are worried, with the assessment centers being ramped down, we're going to really need to see maybe more people do more testing in our offices. So people are wondering what kind of tests you do in your office. Is it the rapid swabs? Is it the PCR? And so it sounds like you're doing rapid testing. Is that right?
No, we are not doing rapid testing. It's PCR testing. And so people have to wait for the result, and they're advised to isolate until such time as that result is available. So our turnaround is about 48 hours for those tests. And that's what we're doing presently.
Yeah, so lots more, I guess, dialogue in the chat. And Megan, if you wanted to go into there and answer a few of those or questions, I think that would be great. And I'm going to turn it over to you, Liz, now, because I know you've also been thinking about how can family doctors manage some of this in the office, especially with increasing flu-like symptoms in the fall. So Brian, are you able to put Liz's slides up? Thank you.
Yeah, thanks. And thank you, Megan. And, thanks for everyone who's writing in the chat. I do think we're in a period of transition, and that, at least in our clinic, has been about a bit of a QI approach, testing different ways of how do we see people in person. And sometimes it works better than others. So we did go to 20-minute visits instead of a little bit longer to try to manage this. We're seeing some symptomatic patients in our office and are in a dialogue right now with our hospital about bringing in more of these types of patients. Our clinic is located in a hospital. I fully recognize in the chat lots of comments about, my office, is small. We've got elevators. How do we deal with this? And I think this is all okay. I just want to say there is no one way that we are going to do this. I think the move for me that is important is back towards, what is patient-centered, and that is going to involve more in person, but we're all going to have to figure this out. So I guess to me, this is the best of what our community practice can do, is for us to be sharing this collectively in a space with colleagues. So I just wanted to highlight some of the recent changes. So at the end of July, the ministry came out with new updated guidance to our sector. So I'm just going to quickly go through what was in there, and some of that will touch on questions that were in the chat around ventilation, for example. So this was the big one in that document, which was moving from a virtual first to a patient-centered approach. I would note that the CPSO also came out with an updated statement around striking the balance between virtual and in-person care. So I've just put some of that on this slide, and really they underlined also that we can't restrict patients based solely on vaccination status, because that was coming up as a repeated question to them. The OCFP updated our guide to in-person's care, and I think we can put that in the chat for you to take a look at, and I really would direct you to Tara's blog. I thought it was excellent. Next slide. And maybe I'll just, on that last one, I'll just say I noted many of the comments around our specialist colleagues. I think the reality is all of us working in outpatient settings, including our specialist colleagues, are working through that move from virtual to, mostly virtual into more in person. And I think as a college, I just want to tell you at every turn that we are clear in bringing that message that family doctors' offices have been open. The vast majority of us are offering in-person and virtual, that we're working incredibly hard, that the numbers of our visits are back to pre-pandemic levels. So just to let you know, we have your back on that at every turn when we hear that kind of rhetoric. I don't think it's helpful for us to be pitting ourselves against each other, but I do acknowledge that this is a specialist dilemma as well that they're dealing with. So just to speak to that. So on IPAC screening, I was really happy to hear this. I have to tell you, we pushed the ministry for greater clarity and hopefully some updates on the cleaning. So now the cleaning depends on your screening status. So hooray, if you screen negative, we can go back to standard cleaning processes. I actually took a deep dive into this public health document that was put out in 2018, which clarifies what is standard cleaning processes. There's a massively complicated risk stratification. I know Allison is a IPAC specialist. I was pretty surprised when I went back to look at what is standard cleaning process. That in and of itself is on a almost 3x3 matrix, how you decide that. But bottom line is our patient rooms cleaned at least once daily is sufficient. And then continue what we're doing right now if it's with somebody who screens positive. So that's good news. Next slide. A change around eye protection. So patients who screen negative, if they are unmasked, continue to wear your eye protection. So goggles, I think I spelled that wrong, or face shield. And if they're masked, then you don't, then you don't need to use your eye protection. So that's a bit of a change there. Ventilation, we really looked to and pushed a bit at the ministry to have more very specific updates on do we need HEPA filters? What's changed? Can you give us specific guidance? So here's what my best understanding is. The key is get a hold of the people who manage your HVAC, make sure it's installed properly, it's regularly inspected, it's working as well as it can. You can use these other measures, so open doors, windows, fans, and a HEPA filter. But none of these right now are mandated or a must-have. I think if you have an HVAC system that is really poor or not working, then obviously the HEPA filters are going to be helpful. You may want to consider this if you're seeing symptomatic, screen positive patients, that room, perhaps a HEPA filter. But right now there's not a mandate for us to be doing this. And I saw some were putting in the chat, what HEPA filters they're using and where. So maybe, welcome people's comments on how exactly they're operationalizing that. And we've got an update on this and other IPAC in one of our OCFP documents. Next slide. So some changes around the fully vaccinated. So the big one here in general was that for fully vaccinated, if you're asymptomatic and you're a contact, high risk contact, you don't need to self-isolate. There is, as always, this request for you to contact your public health unit for more advice. So some of these rules will change, as prevalence goes up and down, and regionally, prevalence can look different. But that was one change. And then I've just listed below, and I think just for time, I may not go through all those specifically, but some of the minor changes around healthcare workers specifically in vaccination status. So a bit of a loosening there on some of the restrictions around self-isolation. Next slide. So the last thing is the announcement that just came out around the mandatory vaccination policy. So there is not a mandatory, it's not mandatory to be vaccinated in healthcare settings, but it is mandatory to have a vaccination policy. This is what was announced by Kiran Moore. So these policies have to be in effect no later than September 7th. And employees, including in our own settings, have to have either be fully vaccinated against COVID-19, have a medical reason for not being vaccinated, and I'll just elaborate that in a second, or complete this COVID-19 vaccination educational session. And those who are not fully vaccinated will have to undergo this regular antigen testing. So more details on this are to follow. I know we were talking about this just this, in the last couple of days, and I think the ministry details on exactly how this might work, how the testing would work, et cetera, are forthcoming. So I don't have any more details than what we all heard in the announcement. The medical exemptions was not yet specified in that announcement that was made. My interpretation is that we would be looking to, really, we know the medical exemptions for vaccination are very limited. It's severe allergy to the components of the vaccine or to a first dose. Possibly also myocarditis, especially if it's to that first dose, especially if it's severe. But I would say certainly, I would recommend people get, even in those cases, I think it's worthwhile getting that e-consult or a specialist advice on that, because even in some of those cases, myocarditis, if it's mild, for example, may not be considered a medical exemption. Severe allergy in some cases, as you guys know, we're seeing some of those patients have been able to get their second dose with a special allergy plan and precautions. So the CPSO addressed this question in their update around what is considered a vaccine exemption, and they referred us back to in that piece that they wrote, it's referred back to NACI and to our own Ministry of Health guidance on where are the contraindications. And then that leads us back to these severe allergies. So as the main one. So I'll just stop there.
Thanks, Liz.
Yeah.
Thanks, Liz. Yeah, so lots of chatter, and
Great.
I know, David, you have your hand up, but I just want a couple of clarifying questions. One is, does this vaccination policy apply to doctors' offices? So are doctors required to ask all of their workers to have one of those three things? And do we have access to the educational sessions?
Yeah, it's a good question. My understanding is that it applies to community primary care and hospital settings. And I don't have any further information than what we got. And I think, I don't know if, I know Allison and David and I were in some conversation about this. I don't know if you have anything more, David, to add.
I've asked for clarity, and I'm happy if I get the clarity today to make sure that we email all the participants that answer.
Yeah. I think this is
Great.
a bit of the challenge with ministry announcements. There's sort of the intent and then the details to follow. So that's a bit of frustration for sure. So Allison, I don't know if you know any more, because I know you were also dealing with this.
And I think certainly for people associated with institutions, it's likely to change over time. You watched, UHN, who had decided that had a whole testing program set up and decided what they were doing, changed their mind yesterday and have now said that it's going to be a vaccine or medical exemption requirement totally. So I think we can expect not only sort of some uncertainties about what ministry policy is, but also a bunch of changes in different people's approaches over time as everybody struggles with, what the right thing to do is here.
So, and it looks like the ministry has put out some guidance on accepted medical exemptions, and Matthew Tenenbaum has posted that link in the chat. So we'll be sure to circulate that to everyone. I know that there have also, and so what I'm hearing in the chat is we need that clarification around, what doctors' offices should do. We also need digestible information around things like how we can have safe ventilation and HVAC and HEPA filters within our offices. So I think someone mentioned the guidance is like 15 pages and they need, digestible information that's practical. So we hear that takeaway too. I also saw lots in the chat about the frustration of standalone virtual walk-in clinics. And so just want to acknowledge that frustration. And it's going to be probably an even greater frustration because now, there was this moratorium on counting outside use against your access bonus, and that moratorium has gone away. So the access bonus kind of previous rules will come into play. And a lot of people saying that it would be unfair if they're, just doing the virtual and saying then go to the ED to do your full physical or to your family doctor. I also see that there were a lot of questions about, rapid testing. And just also frustration of even getting PCR testing if you want to do it. So somebody mentioned that, they get 6 swabs for per doctor for a 2-month period. Somehow that's like they're allocated a very small amount. And so those are things that we need to advocate for better. And what we're hoping at a future session to bring someone in who can talk about their experience using rapid testing, because that's, I think, become new and it's not very many doctors who are doing that in their clinics right now. For the time being, I think, David, you mentioned that assessment centers have been told they can't close. I will say, though, that our own assessment center at St. Mike's is closed to the public, so I don't know how to merge those two things. Alan mentioned that, for example, in New York, they've made a decision to stay open, really to balance that thing around IOI and protect family doctor and ED visits.
Yeah, I believe they've been instructed yesterday to reopen, Tara.
Okay. So lots of amazing dialogue in the chat. I haven't been able to follow it all, I'll admit, but I want to turn our attention now to some of the questions in the Q&A and then turn it over to Allison for her update. I want to start, though, Allison, by asking you a question about IPAC that Alan Grill put into the Q&A. So Alan says, I'm starting to hear rumblings again that we should be wearing N95 masks in our offices and maybe even N95 masks in public, as the Delta variant is way more contagious than previous variants. Is this true? What do you think, Allison?
So, this is a place where there's still a lot of uncertainties and a lot of variability in what experts think the risks are and consequently what the recommendations are. So the first thing to remember is that if you're doubly vaccinated, your vaccine protection against even Delta for serious disease, we'll come back to the rest of it, is still really high. So that does change some of the concerns about, how much we're worried about small particle and aerosol transmission. Then you need to, if you're thinking about the air as a risk, you need to sort of think holistically, because it's not just whether you have the mask on when you're with the patient, it's whether the person who's shedding COVID also has a mask on that fits very well. And it's about what happens to the virus in the air after they leave the room, because if, small particles of virus in the air get diluted, but they don't vanish. So I think, so my answer to that is, I'm comfortable if you're fully vaccinated and seeing patients and wearing a surgical mask. I'm a little more comfortable if you know you have good ventilation in your office. I think the probably the least important thing is you wearing an N95 respirator. On the other hand, if you wish to wear an N95 respirator, it's possible it's going to offer you a little bit more protection, and that's an absolutely fine thing to do. So I know that's an unsatisfactory answer, but I think the really short answer is we don't know with confidence whether it's going to help. And if you wish to be precautionary, it's fine. If you find them uncomfortable and difficult to deal with, it's not one of the things I'm losing sleep over.
Thanks, Allison. And then, we're going to be now moving and switching gears into vaccination more. And I'm going to get Brian to put your slides up. As he's doing that, Carol Mills has asked a question just about people refusing vaccination and whether there's a standard response letter that we can provide them. And I don't know, Liz or David, whether you know of some such thing.
Sorry, I just missed that. I was reading both the chat and the Q&A at the same time, and then
So Carol Mill asked this question. Yeah. It's the second question in the Q&A. Is there any resource for a response to letter from patient refusing vaccination and requesting ivermectin, et cetera? Do we have templated responses, I think? And it sounds like you did cover, Liz, that the exemptions, and we put that link in the chat as to what the exemptions are. They're very limited: allergies, possibly first, myocarditis to the first dose. So we can review those. Anything further you wanted to add?
I wouldn't have anything to add to that, no.
No, I know there's a CPS. The only thing where I saw, and I'll find it and post it in the chat or in response, was the CPSO has written a policy around mask exemption requests. And okay. If I'm not mistaken, it's basically says that you're not actually giving them an exemption, you're giving them a letter because they've requested one, but you can write in the letter that there's no exemption to mask wearing for this patient, which is not okay. For the patient, but you can give them the letter. I'll find that what the CPSO policy is, but I don't think there's one on the vaccine yet, probably mostly because the government just came out with this idea of medical exemption.
Thanks, David. So we're switching gears to talk more about the vaccines, including the latest on myocarditis. If you haven't seen it, I just wanted to draw attention to this new resources that some of us have put together, led by Noah Ivers, just to help family doctors with actually managing symptoms of patients who come in with symptoms of myocarditis. So if you're seeing someone after a vaccine who has palpitations, shortness of breath, et cetera, this is an important algorithm for you. So we'll put that into the chat. So I'm going to go to the next slide, and I'm going to turn it over to you, Allison, for more of an update.
Okay, thank you, Tara. All right, we're going to fly through these slides now. Let's start with myocarditis and to point out two pieces of good news and the uncertainty that remains. So no new updates on incidence, which is good. Okay, not going up, no flags that there's more serious disease. And now two papers, and I thought the references were on the slides. They seem to be cut off at the bottom on my screen at the moment. Looking at a case series of myocarditis associated with vaccine, which demonstrates that this is it looks like it's really quite a mild disease and essentially everybody recovers. So I think what that's telling us is that what the CDC and NACI originally recommended, which is you don't change your recommendations, was the right thing to do. And particularly in the face of Delta coming, I think this is the time to start saying to people who have been looking at young men and saying, we need to wait on this, that it's time to get their second dose of vaccine. And the graph is just to point out to you that one of the challenges with myocarditis is that there's a baseline risk of myocarditis, and we're just looking at an increase over baseline. So particularly in older adults, if you see myocarditis and pericarditis after the vaccine, it's probably temporal but not causal. The causal relationship really looks like it's limited to young men and in the first 4 or 5 days after vaccination, but this is going to cause ongoing difficulty because in individual cases of myocarditis, you're just not going to be able to tell whether it's vaccine associated or where there's some other cause of myocarditis. It's so hard to identify what myocarditis is from. Next slide. Okay. There's been some questions about, ongoing questions about whether you should get vaccinated if you've had COVID before. Nice MMWR article that came out a couple of weeks ago. It's a case control study, so it doesn't give you absolute risk, but what it does demonstrate to you is that people who'd had COVID before who were fully vaccinated were 2 times less likely to have a repeat case of COVID. So just reassurance that although your overall risk of COVID may decrease significantly if you've had COVID before, vaccination still offers you a significant benefit in reduction of disease. And again, just validates what NACI and ACIP have been telling us, which is that even if you've had COVID before, you should get 2 doses of vaccine. Next slide. Okay. Now let's think for a moment about what our challenges with Delta are. And on the left-hand side of this are just the list of questions we might want to ask about Delta versus right is my attempt to make sense of it. Okay, so disease severity with Delta is at least that of Alpha and probably even higher. So it does look like there's another bump up in disease severity from Alpha over Delta, and Alpha is about 1.5 over Wuhan. So we are looking at more severe disease. Listening to people in the States, you would think that there's an even greater bump in children, and we'll come back to that in just a moment. To me, that is still uncertain. We know transmissibility is substantially up. So we went to reproductive number, right? In the absence of any controls, 2.5 to 3 cases from any 1 case for Wuhan, 4 to 5 cases for Alpha, 7 cases for Delta. Okay, so there's the reason we're in trouble there already. In terms of vaccine protection, and you'll see more slides in a minute, the protection against severe disease with Delta is holding up for everybody. Okay, so in terms of individual level protection against severe disease, which is what you really want out of a vaccine, we're fine. However, individual protection against milder disease is not as good in healthy adults. So there's a decline from the original sort of 90-ish% down to 60 or 70%. And worse yet, if you get infected when you're vaccinated, it looks like you carry the same amount of virus in your nasopharynx, which suggests that you're as likely to transmit. So you still get the benefit from vaccination in terms of reduction in disease. And of course, that reduction in disease translates to less risk of transmission. But if you get disease, you're still going to transmit it maybe as much as unvaccinated people. And that's what has put paid to herd immunity. Okay, we're all just sitting now saying, we really don't know whether there's going to be any herd immunity with Delta, or whether we're just looking at, we have to count on individual level protection for everybody. And that, of course, is what has changed so much of the discussion about vaccine. Next slide. Okay, what's going to happen in the fall? Well, if you look at this slide, this is a bunch of countries that have high vaccination rates. Remember, when you look at vaccination rates, the Our World in Data gives you total population vaccination rates, and somewhere between 10 and 25% of countries' populations are kids. So if you look at Israel, it's 61% double dosed. That translates to more than 90% of adults. Okay, Israel's got a really young population compared to Canada, but these are all high vaccination countries with very different rates of disease. And if you look at the correlation is actually with public health restrictions. So through June and July, as Delta takes over, what's actually been keeping the case numbers down is public health restrictions, not vaccines up to a level of 50 or 60% second doses. And of course, it's been nice being Canada at the bottom. Next slide. But it's over now. Okay. So when we moved into the third wave and on the third step in Ontario, the reproductive ratio of the virus has gone up. It's now running about 1.3. So we are, as one of the modelers said to me yesterday, very depressingly, we're in the exponential phase of growth of the Delta phase now. So we're definitely into wave 4. And what happens is going to depend on how many more doses of vaccine we can deliver, whether there's some level of herd protection. There may still be some, even though it's getting depressingly low. How people behave in terms of keeping their contacts down and their mobility down, and what public health restrictions we're going to put back in. So all of that is going to be the balancing act over the next few weeks about what we need to do to keep hospitalization rates down, and how far we can push vaccination rates up. Next slide. Okay, and the complicating factor, of course, is that with adults, the case to hospitalization ratio has changed. When you get vaccinated, if you get disease, it's likely to be much less severe. So now there are many more cases per hospitalization, and understanding exactly what that looks like with Delta is still really hard. And I put this slide up because you can see that there's a huge range and variability in those countries with high vaccination rates, with pretty much similar public health restrictions. And I don't think anybody understands why there's so much variability. And that adds a layer of uncertainty, because we don't actually care about preventing cases, okay? It doesn't matter if we have a bunch of people who have 3 days of fever with COVID, right? What matters is if people are hospitalized and get severe illness with COVID. And so because other countries' experience is still uncertain about how much decoupling there is between cases and hospitalizations, we just don't know exactly how much we have to do over the next few weeks or the next couple of months. Next slide. Okay, now the question about, is this worse in kids? So this is data from the US COVIDNet, which is, I don't know, a large number of hospitals across the US looking at hospitalization by age groups. And so you can see, if you look at this, that the ratio of hospitalization is changing as people are vaccinated, with older people being much less likely to be hospitalized, relatively speaking, and younger people who in general are less vaccinated going up. But you can also see that the kids data down here in the yellow and gray is not higher than it was at peak. So it does not look, looking at this data, next slide, and you can see it a little bit more clearly if we take the over 65s out, which are really up, and just look at under 65-year-old age groups, we're not at hospitalization rates that are above where they were in January. So it looks like we're paying more attention to kids because they're a higher percentage, but maybe their actual risk of disease is not changing. And if you try the same thing looking at how the UK sets up data, next slide. This is data from Health Protection England, and what it does is it asks about rates of hospitalization in the first week of August compared to rates of hospitalization at their peak on the 17th of January. And what you can see is that in older adults, the hospitalization rates are way down because of vaccination, but in kids, they were back up to the same rates they were at in January. Again, suggesting that what we're seeing in pediatric disease is not actually an increase in pediatric disease. It's just our sense of it is higher because older adults are getting less sick. But, you know, I honestly, I think the jury is still out on how much more severe disease Delta causes, and whether we're going to see an increasing sort of overall risk of severe disease in kids. Next slide. Okay, now, third doses. Been the topic on everybody's mind this week, and it starts with the Pfizer analysis posted now on medRxiv, looking at the change in protection over time. So when they looked at very early protection, 7 days to 2 months after the first dose, it's 96.2. It drops to 83.7 after 4 months. And that's why Pfizer came out and said, we're worried about declining immunity. We think people may need a third dose. You'll hear the difference now. People are not talking about boosters. People are saying, maybe we just need 3 doses as part of the primary series to maintain protection. So the language is changing a little bit. But remember, again, that this is decline in protection against any degree of symptoms. It's not decline in protection against severe disease. Next slide. It is, however, really different for seriously immunocompromised patients and for residents of long-term care. So this is the Kumar study of neutralization before and after the third dose of vaccine for transplant patients. And here you can see that the transplant patients have very low neutralizing titers, and many of them have low neutralizing titers even after the second dose. Their titers go up when they get the third dose. So good reason to think that in these really immunocompromised patients, you're getting some benefit from giving a third dose to this specific subgroup of patients. A number of people have asked in the Q&A about, what we know about the relationship between immunogenicity, neutralizing titers, and protection against disease. And the best I can say is there is one, okay? Higher neutralizing titers are clearly better. Now, you want details. Is there a threshold? Do we know what the relationship looks like? All those questions are still open questions, don't know the answer. So you can only look at this and say, third dose in transplant patients significantly increases the proportion with neutralizing titers, almost certainly will translate to some increase in protection. How much of an increase? Don't know. How long will it last? Don't know. But vaccines are pretty inexpensive. And so when you look at this, you say, given all the uncertainties, still probably worth a third dose of vaccine in this population. Next slide. And then if you look at long-term care residents, which is the other group of people we've included in Ontario, you can see on the left-hand side in the blue bars, you actually get better antibody levels with Moderna, although it doesn't seem to translate into better protection, interestingly. But again, it's some number between 10 and 20% of people who don't get neutralizing antibodies. And if you look on the right-hand side, you can see the decline in any measured antibody at 4 months. And so it's that combination of there's some non-responders who might respond to a third dose, and the decline in antibody levels in long-term care residents is much faster. So you and I will have lost about 10 or 15% of our antibody concentration over that 4-month period. Long-term care residents have lost 50%. So that combination is, and the increased risk in congregate living settings is what's saying to us, given all the uncertainties, still worth an extra dose now because of the protection it might afford going on. Does not translate, however, to the rest of us who still seem to be doing okay. Next slide. Okay, so these are a couple of the studies that have come out of the United States this week. On the left-hand side, a big study of effectiveness against COVID, where you can actually see the decline in vaccine efficacy from around 70% in the period before Delta took over, down to about 50% in the period when Delta has taken over, which again is why third doses in that population makes sense. And on the right-hand side, an overall effectiveness study in New York State, demonstrating that yes, vaccine efficacy against mild disease overall has declined from just above 90% to about 77 or 78%, but protection against severe disease is holding. So you can look at this graph and make two different conclusions. You can do what President Biden's team has done, which is say, that rate is declining. It may continue to decline. It's going to be really popular with a lot of people if we say you can get your third dose. So let's go for third doses because they may be a benefit. Or you can look at it and say, there are millions of healthcare providers around the world who have not yet had a first dose of vaccine. We have no way of knowing what the shape of that blue curve is. It might flatten. Okay, protection might be maintained at 78% over the next 2 years. Okay, and until we know more, it makes a lot more sense to try to be directing as much vaccine as we can to other countries, and living with the fact that those of us who are healthy adults, have a somewhat higher risk of getting symptomatic disease, but not a higher risk of getting severe disease. So you've seen, I think across Canada, we will likely maintain that we are not offering third doses outside of very specific circumstances where we know that either people don't develop antibodies and they improve post-vaccination, or as in long-term care, where people's antibody levels decline much more quickly than the rest of us. That does not mean that we're not watching really carefully to see what that protection is going to be over time, and that we won't move to third doses eventually. It is, I think from my perspective, is looking like we're probably going to want third doses for most of the population at some time. But I don't know that with confidence, and I think we just need to wait and see what's going on. Next slide. Okay, and then you can read this on the website. Here's what we've decided about third doses in Ontario so far: really limited immunocompromise and residents of long-term care. Next slide. And then lastly, somebody asked what we're watching for variants. Okay, so there's 2 on my list, which probably just reflects the fact that there's a whole bunch of others that virologists know about that I don't know. One of them is B1.621. Which has increased in Ontario from 0 to about 3%. Who knows where it's going? And one of them is a Tanzanian variant, which people are worried about, not because it seems to be spreading around the world so much, but because it's evolved from a very early version of the virus. So it's more different than other ones. If you look at the picture, the E484K, the N501Y, the P681, the D614G, the D950N, those are all what we think of as standard mutations now. So it's kind of good news and bad news. It looks like the new variants have the same old mutations, which is promising and may mean that we're at some limit. It's not going to get much worse. But, obviously, coronaviruses are coronaviruses, and only time is going to tell whether they have any other nasty surprises in store for us. Thank you. That's the end of me, Tara.
Wow, Allison. I mean, I think I've learned so much in that last 20 minutes. I think it was informative, and also for me personally, there were many aspects that were actually reassuring as well. So to be able to see that continued vaccine effectiveness against Delta for severe hospitalizations, but lots of uncertainty still on the path down the road. So thanks for that really deep dive. I know I'm going to actually, I think, watch our recording again, because there was so much in there that I want to know more about. So thank you, Allison, not just for this talk, but actually for all of your talks to us over the last few months. I think thanks to you, those of us who are on the webinar are continually feeling like we're up to date on the latest evidence and have a perspective that's nuanced, beyond what we hear in media or social media, which can sometimes feel quite rhetorical. So thank you. Thank you too to Megan Stephenson for sharing what you do in your practice and what you have done, and for the amazing discussion that all of you guys prompted in the chat. You've raised some really excellent questions that we know we need to advocate on your behalf for policymakers and for more clear guidance. I think what I'll ask is, as we send out the evaluation, please do let us know what you want to hear more about in our next session. So do you want to have the next session, in 3 weeks, 4 weeks, when? And who do you want to hear from? What are the questions that you want to know? So please let us know, because we really take that very seriously in planning. So thank you to everyone for the amazing work that you continue to do. Thank you to our co-hosts and all the people behind the scenes to make this happen. And I hope that all of you do get some time to rest and enjoy the outdoors in the summer. We know outdoors continues to be safe, and so it does feel, it feels nice to be able to do that at this time. So take some time away, you deserve it. Take care.